Welcome to this IAS Educational Fund virtual meeting, and it's a real pleasure to welcome those of you who are with us today for the first time and those who joined us yesterday and have continued to take part in this workshop. And it's my great pleasure to tell you, my name is Linda Gale Becker. I'm from the Desmond Tutu Health Foundation, that today the Desmond Tutu Health Foundation is co-hosting this with the International AIDS Society Educational Fund. And I did want to just put in a plug for the International AIDS Society Educational Fund. This is a wonderful initiative that came about from the IAS a few years ago in recognition of the fact that whilst our conferences, which you are all very familiar with and occur every year, one being the large International AIDS Conference, the other being the HIV Science Meeting, and of course now also R4P, Research for Prevention meeting, that whilst those are very important to disseminate information, we do want to see that information, the best science, getting into policy. And one of the ways we've recognized to do this is to move regionally from time to time, bringing the best science and making sure that the right people are in the room to hear that science and translate it into policy. At the end of the day, the International AIDS Society is about people, science, and progress. And each one of those are important. People, our members, the people we serve, people who live with HIV, and others who are at risk of HIV and related conditions. And of course, the science, something we're very passionate about, evidence, and then finally progress, that we actually do move towards an AIDS-free world. And this workshop we've entitled The Last Mile, the Longest Mile, recognizing that ahead of us from 2021, as we move towards the 2025 goal and then the 2030 goals, that this is probably going to be the hardest work we've had yet. That we really do need to examine the evidence and ask ourselves what else we can be doing as a collective to realize the promise of an AIDS-free world. And this is particularly relevant in the Eastern Southern region. So these workshops are slightly different to what we normally do. We've kept numbers small. It is on an invitation-only basis because we wanted the right people in the room to say, how do we put our minds together to come up with actionable items? And today we will, after we hear from our keynote speaker, we will be breaking into small groups to actually try to get very tangible and very granular about what the actionable items are in each of these topics. So yesterday we talked about prevention and pre-exposure prophylaxis. In the afternoon, we had a very important and wonderful session, which I hope all of you attended, on the responsive clinical care for children living with HIV. And those are both going to be available to you. The prep is already available on this platform to watch in your own time if you didn't get there. The responsive care will also be available. And today, our topics, again, the final eradication of mother-to-child prevention or vertical transmission, as well as better care for children. And then finally this afternoon, we asked the question, is health relevant without mental health? So can we talk about health without mental health? And so I'm hoping both the session this morning and this afternoon will be really very valuable to all of us. So today we will be focusing on children's lives. When did we stop caring? And that's quite a provocative topic because I think as Amina, our keynote speaker, will discuss with you, we seem to have lost the plot on eradicating vertical transmission and ensuring an AIDS-free generation in our children. So we will be turning our attention to that. But before we do, and before I introduce Amina to you, I'm going to thank, first of all, Lauren and Camilla from the IAS for working so hard to put this wonderful workshop together. And I'm going to hand over to Lauren for the housekeeping that we need to think about this morning.
Yes, thank you very much, Professor Becker. So welcome, everyone. Let's try and wake each other up this morning. These are just some housekeeping rules. But yes, as Professor Becker said, my name is Laurent Botti. I'm the Associate Project Manager at the IS Educational Fund. And I'm just introducing myself because I'll be, you'll see my face throughout this workshop. And I'm also here with our IS Educational Fund colleagues, Laure Felix Bauer and Camilla Vontora. So if you have any questions, please don't hesitate to reach out to us on the chat on the platform or by email at isedu@issociety.org. So for the moment, I just wanted to let you all know that you are all muted, but then we'll all split out into the breakout rooms for the group discussions. And that's where we'll encourage all of you to speak and provide all of your input as much as possible, because that is really what we're trying to aim at here, trying to, as Professor Becker mentioned, reach the actionable items for today's topic. So that will be at a later stage. We will send you all by email a Zoom link to access those group discussions. And you will also see that link here on the platform. So please let us know if you have any problems accessing that. So for the moment, I know a few of you are already probably very familiar with this platform, but if not, there's a chat box right underneath this screen. If you could just please introduce yourselves with your first name, last name, organization, and the country you're from, that would be great, so we can start chatting and being more dynamic and meeting each other a bit more. There's also a chat function further down on your screen where you can speak individually, and you can also do some video conference calls with people independently. So you can also do this outside of session hours. So please use this as much as you'd like. We encourage you to network virtually like this. The other thing I wanted to mention is that this workshop is CME accredited. So if you participate in all of our sessions, then you'll receive 6 credits in total. So it's 1 credit per hour that you participate. If you're interested in receiving these credits, please reach out to the IS Educational Fund team, and we'll be able to let you know what information we need from you to be able to provide you with those credits. And then the other thing is we also have some pre-reading material that's available on the platform. As Professor Becker also mentioned, all of the recordings of the sessions will be available under the resources page, and presentations will also be available there. And we will also have at the end a report that we will upload on this platform for you to read, but that will take a little bit more time, as we have some rapporteurs who are doing a fabulous job at taking notes to prepare this for all of us. And now, before I hand back over to Professor Becker, we'll do a little bit of introductory polls. So hopefully you'll be able to see on your screen. We're going to launch some polls, and we're going to ask you how you're feeling today. And then we'll also ask you what expectations you have for this session. So for the moment, hopefully you'll see a poll that showed up on your screen. So it'd be great to see how you're feeling. If it's sleepy this morning, confused, are you excited? Are you curious? And oh, so I see a lot of people are doing great. A few of you are sleepy. I totally understand. I have my coffee with me. So, okay, let's move on to the next question. So with poll number 2, now you'll see what are your expectations for today on your screen. To gain a better understanding of HIV science and new developments, getting ideas and finding solutions for the challenges that you might face at work, gaining opportunities for collaboration in order to improve HIV policies and programs in your country or your region, finding new strategies on how to improve HIV policy and programs regarding implementation science, or perhaps gaining new contacts through our chat. Let's see. So it's quite an overall look, I see the highest is getting ideas and finding solutions for challenges you face at work. So that will be great, actually, because we'll be looking at this during group discussions. So thank you very much. I hope that you enjoyed that little opening. I'll send it back to you, Professor Becker. Thank you.
Thank you very much, Lauren. And we really move into the business of today again now, focusing on children, on PMTCT and an AIDS-free generation. What actually needs to be done? Where have we lost our way and how do we get back on track? And to set the scene for this, it is my pleasure to introduce to you my very good friend, Professor Amina Goga, who is not only passionate about children and the elimination of vertical transmission, but is also a very busy unit director at the SAMRC HIV Prevention Research Unit here in South Africa. And as if that is not enough, I can also tell you that at the moment she joins us on the Sisonke 3B program as a co-PI and has been working tirelessly night and day to make sure that vaccines are reaching our frontline healthcare workers at the moment. And so for that, I think we all owe her a debt of gratitude. And I am so grateful that despite all that busyness, she agreed to step in and share some of her reflections. And again, this is really just to set the scene for all of us on PMTCT for an AIDS-free generation, linkage to care and treatment. So over to Amina. Thanks.
Good morning. Thank you for the invitation to speak at this workshop. I'm going to talk about PMTCT for an AIDS-free generation, linkage to care and treatment. In my talk, I will focus on eliminating vertical transmission of HIV. Where are we? Then I will focus on linkages to care and treatment. The first thing I want to remind us about are the two impact indicators that we use to measure the elimination of MTCT. The first one refers to the MTCT risk, and there the target is to have less than 5% of vertical transmission of HIV in breastfeeding populations at the final endpoint. The second is known as the case rate, and here we aim to achieve less than or equal to 50 new infections per 100,000 live births amongst children. There are several other process indicators that go along with these impact indicators. These are indicated on the slide, and in particular, we want to have at least 90% of women, pregnant women living with HIV on ART, to have 85% of women living with HIV on ART before their current pregnancy, and to ensure that at least 95% of women living with HIV are virally suppressed during delivery and during breastfeeding. This slide shows us the number of children aged 0 to 14 years who are infected with HIV between 2000 and 2018. The dots that you see on the slide are the targets that we're aiming for 2020 and 2018. As you can see, although the number of new pediatric infections have decreased significantly between 2000 and 2018, we're still very far from the target. In fact, in 2019, new pediatric infections were 7.5 times the 2020 target. In this slide, I want to highlight that in 2018, breast milk PMTCT accounted for more than 50% of MTCT in at least 15 of the 21 priority countries. This slide unpacks that slightly, and here what you see are perinatal transmissions, so the number of children who are infected perinatally in red. The dotted lines represent the 95% confidence interval. The blue line represents postnatal MTCT, and as you can see, from around 2010, the number of children infected postnatally has been higher than the number of children infected perinatally. In this slide, I want to highlight the case rate, the MTCT case rate, and the target for the case rate was to reduce vertical transmissions of HIV to less than or equal to 50 per 100,000 live births. In this slide, on the vertical axis, you see the cases per 100,000 live births, and on the x-axis, you see the maternal HIV prevalence. What this slide tells us is that if maternal HIV prevalence is high, so 35, 30 or 25% or even 20%, we will never achieve the case rate of less than or equal to 50 per 100,000 live births, even if the vertical HIV transmission risk reduces to 5%, which is in purple, 2%, which is in yellow, or 1%, which is in pink. The only time that we may achieve this case rate is if maternal HIV prevalence reduces to 1%, or if we have a 1% vertical HIV transmission in mothers who have in settings where the maternal HIV prevalence is 5%. So we're quite far away from achieving the target case rate to eliminating MTCT. If you look at where transmissions happen, and these are stacked charts that are drawn from UNAIDS showing Eastern and Southern Africa, of significant note is that most new childhood infections are due to incident infections amongst pregnant or breastfeeding women, delayed ART initiation or retention, poor retention on ART. What we find is that 31% of HIV-exposed children are born to mothers who acquire HIV during pregnancy and breastfeeding, and amongst seroconverters, young women accounted for 43% of infections. So we need a three-pronged approach to eliminate vertical transmission of HIV. Firstly, primary prevention, including PrEP. Secondly, retesting HIV-negative mothers or extending infant prophylaxis in infants born to unsuppressed mothers. And thirdly, focusing on new interventions such as vaccines or broadly neutralizing antibodies. So where are we in terms of linkages to care and treatment? And here I have a few slides to highlight the targets as well as where we need to be. The first slide shows that we need a people-centered approach at the center of the pandemic so that we take people's needs into consideration. This slide emphasizes that eliminating mother-to-child transmission of HIV depends on the entry step into PMTCT, and that is retesting or testing of women. Here you see the HIV testing and treatment cascade globally between 2015 and 2019. And what you see is that access to treatment and to testing is still suboptimal. These slides now show the effect of COVID-19 on several indicators. Firstly, the number of pregnant women tested for HIV. And what you can see is that in many countries, there were significant disruptions in HIV testing rates, and many of these have been sustained despite the fact that it's a year post-COVID-19 and we're still in the pandemic. This looks at the number of pregnant women receiving antiretroviral therapy, and you see once again that access to ART has been reduced in many sub-Saharan African countries. This is a slide from South Africa that reports the effect of the first wave of COVID-19, and what you see is access to contraception has been reduced, particularly during lockdown periods. Access to antenatal care has been reduced, and maternal deaths have increased before and after lockdown at the end of March last year. Of note also is that in order to reduce mother-to-child transmission, mothers need to be virally suppressed. This is from national laboratory data from South Africa, and you see that the percentage of mothers who are virally suppressed, so less than 50 copies per mil in the bottom graph, or less than 1,000 copies per mil in the top graph, is significantly less than our target, which is the black line on both graphs. Of note is that there was a delay in returning results, particularly to clinics and to mothers. This is data from South Africa. And then I want to focus now on breastfeeding and feeding amongst infants. Feeding is the optimal strategy for babies. But what you also see here, data from South Africa, is that feeding is also suboptimal. And so we need strategies that will allow mothers to safely breastfeed their children while maintaining or reducing transmission. This looks at the effect of COVID-19 in a province in South Africa, and you see that infant first PCR testing has been significantly reduced. I want to highlight the WHO guidelines, which have recently been updated. And here, speaking to the 3 points that I made before, to reduce new infections amongst mothers, WHO now recommends the Dapivirine ring as part of the guidance. Then focusing on HIV testing and suppressing viral load, WHO now recommends point-of-care testing for HIV diagnosis amongst children and point-of-care viral load testing to monitor treatment amongst people living with HIV. And so how do we resolve some of these challenges that I've highlighted today? Well, firstly, we need critical biomedical interventions to reduce postnatal MTCT through breastfeeding. Some of these are HIV vaccines, BNABs, or PrEP. We need people-centered approaches and particularly community-based interventions to facilitate early ANC booking, to increase ART uptake and adherence and sustain viral suppression, and to increase the uptake of routine services despite the effect of COVID-19. And lastly, to put in place health system programmatic interventions, particularly to integrate point-of-care testing into routine services, to improve routine data quality, to strengthen the postnatal care platform, including breastfeeding support, and then to do all we can to mitigate the effects of COVID-19 and to continue providing sexual and reproductive health and MCH services to everyone in need. Thank you very much.
Well, that was an amazing tour de force. Thank you, Amina. We really, I think, value being reminded of the long road ahead. And I think it's particularly disappointing on some levels because I think in 2015, you know, we were on that sort of plan to eradicate mother to child. What do you, I mean, let me just put that question to you, Amina. What do you think has gone wrong? I mean, why, you know, are we in this position today in 2021 when we were on a global plan to get rid of vertical transmission?
Yeah, thanks so much for that important question. I think we were so encouraged by what we saw between 2005 and 2015 that we started becoming a little bit complacent, and we saw that transmissions had really been reducing in the antenatal period. And so that contributed to, during pregnancy, and that contributed towards some of the encouragement that we all experienced. But then we forgot that there's a very complicated postnatal period. And the postnatal period in particular is complicated because you have a new mother who goes through various emotions and changes of her own. And so we need to make sure that she's on ART, that she's virally suppressed and well, and that she's breastfeeding or feeding in the best way possible. And I think our postnatal care platforms haven't really been kept up to speed. And so as a result, you saw on the one graph, we reached a certain point, and after that, the intrauterine transmission started coming down, but the transmissions postnatally started increasing, so contributing towards more infection. And so we really need to pay attention now to that postnatal period without neglecting the antenatal period, of course. So I think that's what happened.
Yeah, thanks, Amina. And I'll just remind everyone, please post your questions in the Q&A. I'm monitoring that as well, so do so. And by all means, also keep your questions and ideas and bring them to the breakout session in a moment. But just to continue that theme, because I think, Amina, you raised pre-exposure prophylaxis in pregnancy as such an important first kind of rung to making sure that we don't see incident infections during pregnancy, because obviously that's really high risk for transmission. But we're finding the same problem, that keeping PrEP going in the postnatal phase is tricky. you know, any big, I mean, it's a big question, and I realize that, but any sort of immediate tips that you, or actionable items that you think we can really pay attention to in terms of postnatal care, which, as you say, is complex?
Yeah, I think we need to work on two levels, and the one is healthcare providers, and then the other is mothers or pregnant women who need to access services. And on the healthcare provider side, there's the manager side, and then there's a manager or policymaker, and then there's the actual healthcare provider. Many policies do say that we can now start PrEP in pregnant women, and now that we've got long-acting or the Dapivirine ring, that's even better. But what we find is that many policies say that they should be initiated by a doctor. And so we need to change that. Doctor-initiated PrEP will not take us very far, and so we need to look at that policy level. Then we need to look at the attitude of healthcare providers. Not everybody's comfortable with starting PrEP in pregnant women or breastfeeding women, and so we need to do some advocacy and training around there. And then we need to look at women. And, you know, I think this thing of people-centered care is so important. People are humans and they're people. They go through issues in life, they're crises, and we need to make sure we provide that support and encouragement to make sure that people initiate and then sustain whatever intervention or, you know, whatever modality they've chosen to be on for PrEP. So I think that's the way I'd answer that for now.
Thanks, Amina. I think that's great. I see some lovely questions starting to come in, Ilona. I hope that sort of got to your points around the factors. I wonder if you could just pick up for Linda quickly, Linda Stranix, who will also be taking us through the next session, Amina. Just the question of age, just that factor around age. I know you highlighted a bit, maybe just emphasize in a few minutes your thoughts.
Yeah, I think age is a huge factor, and in two respects. One is that we find that younger women, and these are not only women under the age of 20, but under the age of 25, they do have more difficulty accessing services, so their coverage is less, or they start accessing services later. So their coverage is then less, and then they do have a higher transmission. And so paying attention to younger women needs to happen on various levels. You know, it's not just about, let's say that we need to pay attention to younger women, but what needs to be done at a health facility level with healthcare providers who are in the facility, who see young people and who are still, unfortunately, not always supportive to provide the care that the young women need. And so, you know, we've had several initiatives, we've had youth-friendly health services, and they all seem to come and then they seem to fizzle off a little bit. And I think now it's time to start, not just kind of soul buddies or buddies kind of clubs, but to have an overall social mobilization approach to this, because it's not just about a health facility, it's not just about pairing people up with a buddy. It's about a whole community or a whole country's approach to young women to make sure that they get the care they need at the time they need it, because many times the care is delayed and then there's interruption in care as well.
Thanks, Amina. I'm so sorry that this is virtual, because I think if we were in person, we would all be standing up and you know, shaking our giving you a standing ovation for that. I couldn't have said it any better, and I really hope that'll come through in our next session of actionable items, that we need a social mobilization. It needs to become in our fabric of society to support young women, not only through their reproductive needs, but throughout their whole, you know, their whole sexual reproductive experiences. So thank you for that, Amina. Thank you for your time. We hope you'll stay with us as we move into the second session. So it's my pleasure now to welcome you to do that. We will be looking to find actionable items and build consensus. And to help us do that, I'm now very happy to hand over to another pregnant woman champion. Linda Chibanda Stranix is a lecturer from the University of Zimbabwe Clinical Trials Research Center in Zim, another good friend. who does amazing work in this area. And so I'll be handing over to her. But before we do that, we need to move to another platform. So please look on your screen, you'll see that. Otherwise, we are emailing you the link. You will need to move to that other platform in order to join the second half of this workshop. That will take you into a breakout room and you will be able to reconvene. So don't worry, you're not leaving us completely, but you don't need to be on this platform anymore. I hope that's clear, because we lost some people yesterday and I suspect they're still wandering about in cyberspace, which is very worrying. So please note, either in your email or on the platform, you will see a place to go now to your breakout. We also invite you now to go find a cup of something that you like, or a snack. You have 3 or 4 minutes before we will convene with Linda. So thanks again, Amina. Thanks to the team, and thank you for joining us again this morning. Off to your breakout sessions now. Bye.